Alaikum warahmatullahi wabarakatuh. Welcome everyone who are listening to our talk today. This talk is part of the Saudi Critical Care Pharmacy Research Group, SCAPE group. It's part of their initiative that's called Loading Dose. And our focus today, our loading dose today is on data synthesis and meta-analysis. And we're going to focus specifically on effect measures, their different types, what do they mean, and how do you combine them. And we're going to talk also about random versus effects model. My name is Hadeel Alkofide. I'm an associate professor at the College of Pharmacy in King Saud University. My talk today is just, as I said, part of the series of floating dose lectures presented under the SCAPE platform. These are freely available lectures, just a helpful tool for any researchers interested in performing systematic reviews and meta-analyses. I have no financial disclosures or nothing to disclose financially related to this topic or this lecture. So we're going to have just first going to have a quick review on systematic reviews and meta-analyses, just to freshen up our memories. Then we're going to talk about the types of data and effect measures, how we're going to combine these data and meta-analyses, and then we're going to talk about random versus effects models, and then we're going to read a very simple forest plot, which is the main results of a meta-analyses, and then we're going to discuss heterogeneity and subgroup analyses, and finally, I'm just going to give a summary on my lecture. First of all, let's start with our quick review on systematic reviews and meta-analyses. So just a briefly simple steps when conducting systematic review and meta-analysis. So first of all, you start with like forming your question and then writing your research proposal. And usually I advise that the proposal should be submitted into the Prospero website and registered and have a registration number for your proposal before you start your project. And then once you have your idea ready, your proposal published, you're going to go to the next step in which you're going to search for studies and then screen them. The screening, usually there are two steps in screening, preliminary screening in which you search only the titles, abstract of the studies that you found through your search. And then once any of these are eligible, you're going to screen them, do the full text screening, and then also you're going to hand search possibly eligible studies or similar RCTs or similar meta-analyses, in the topic. This process is usually done independently by at least two reviewers or two extractors, so two data screeners. And then you're going to move to data extraction. So extracting the data also requires an independent work, so it needs to be done independently by two individuals. You're going to extract the relevant data related to your meta-analyses and your question in terms of what are the information regarding the study design, the population of interest, the outcomes, what effect measures was used, and so on. And then you're going to combine the studies. That's, of course, if you're planning to do a meta-analysis, not just systematic reviews. So you're going to combine the studies whenever it's feasible to combine them. And then you're going to analyze your data. And then finally, you're going to be presenting your results in a manuscript or a conference or an abstract poster, whatever. So hopefully all the work will end up as manuscripts. So this is just to freshen up of what are systematic reviews and meta-analyses and the steps that are involved in these types of research. Why do we perform, or the reasons for doing meta-analysis? Usually improve the power to detect a small difference if the individual studies are small, improve the precision of the effect measure, compare the efficacy of alternative interventions that maybe not be possible during a traditional head-to-head trial, assess consistency of effects across study and patient characteristics. You're going to gain insight into statistical heterogeneity, help and to understand the controversy arising from conflicting studies or generate new hypotheses to explain these conflicts, and force rigorous assessment of the data, the published data, whether from RCTs or observational studies. There are many reasons why we would be conducting meta-analysis. So let's move on to types of data and effect measures, and what do they mean? So what is an effect? So in systematic reviews and meta-analyses, we use the terminology effect measure or measure of association. It's a way to describe the outcome of participants treated with a different intervention or exposed to different factors. So depending on the type of data, the type of measure will differ. So we don't usually say mean or odds ratio, we say effect measure. So effect measure means whatever measure they're using in the study to describe an outcome. either in interventional studies or randomized trials or in observational study in terms of there's exposure or non-exposure status. So what are the types of data? It's just general type of data in the statistics. We have dichotomous or binary data, we have continuous data, we have ordinal data, counts, time to event, and so on. Maybe there's other types of data that are not mentioned here. So our question here is, when you think about type of data, it's very important because it will affect, this is the effect measure. So your effect measure, what's the type of data they're using for that measure, and that will determine the type of test you'll be using in the meta-analysis. This is just an example of type of data. Age can be in years, and then age can also be, as here, like here we can see age in years, so it's a continuous variable, and they have it as mean, median, and then range, and of course, and then deviation with the mean. And age can also be categorical. So usually any continuous data can be converted to categorical, but not the other way around. And that's very important meta-analysis because sometimes some studies are being reported, they report the outcome you're interested in as a continuous variable, and in other studies as categorical. So there are ways convergent. We might talk about them briefly in our presentation today, but conversion really depends on the study you're doing and the effect measure. So there are different, very wide range of conversions that you might end up doing in a meta-analysis. But usually categorical data, like for instance here, sex, male and female, cannot be converted to a continuous variable. So if you can think of if you have continuous and categorical for the same outcome, let's say your outcome was a C-reactive protein level, was it reported as a continuous outcome or reported as a categorical outcome? So you might be able to change the continuous into categories, and then you can combine the outcomes together. So it depends on the type of data, we can choose the effect measure we're interested in. So if we're talking about continuous variables in which we have mean or median and so on, we can use mean difference, will be one of the very common ways to combine data in a meta-analysis. And we can also use standardized mean difference or correlations if it's using correlations, if the original effect measures are correlations. So just the difference between mean difference and standardized mean difference is that we use standardized mean difference when the units of the continuous variable are different across these. So let's take maybe a straightforward example, blood pressure, in which the measures, the unit is usually the same, millimeter mercury. So in that instance, because we know that most people will use the same unit, so we can combine blood pressure together using mean difference. So mean difference will be our effect measure in the meta-analysis. So the outcome they're using was blood pressure continuously, and our effect measure now is mean difference. So we want to see the difference between the groups of whatever intervention, exposure and non-exposed. So when do we use standardized mean difference? When we have different measure units. So let's say, for instance, your outcome is pain score, and they're using different, and each study is using a different pain scale. But they're all pain scales, a scale that measure pain, but they're different. So the units are different in that scale, so they're not the same scale. So in that instance, when the unit is not the same, but the measure is the same, so the same variable, it's pain, but it's not the same scale, the same unit, then you can use standardized mean difference to overcome the issue of different units. When you have dichotomous or binary data, which is one of the very I face one of the very most common outcomes in studies, because such as death, hospitalization, new events, all of these are considered dichotomous, yes or no kind of outcome. For these outcomes, the effect measure can be odds ratio, or risk difference. You can either obtain the data directly from the studies, so study will report number of deaths across the groups between two interventions, so you can calculate the odds ratio, risk difference, and then combine them together. And sometimes the study reports adjusted odds ratio. So in that scenario, these are not raw data or not just number of deaths. These are adjusted, for instance, death rates. Then you can combine the adjusted odds ratio together. So this is, it will be the same kind of concept, but the analysis is a bit different. The tests you will use in your program will be different. These are adjusted odds, or the just odds ratio you collected, or raw data. And then for time to event, you can combine them with hazard ratios. In some scenarios, we do combine, if studies report odds ratio, let's say the outcome is death, time to death. So some studies reported time to death, some studies reported death as odds ratio, some as relative risk, and time to death, of course, is hazard ratio. So we can combine all of these together, but this, of course, we have acknowledged the limitation that we're combining different, slightly different effect measures, but it's not heard of. Like we can combine the odds ratios, risk ratios, and hazard ratios, or we can convert them. If we can convert one to another form, that would be the best way. But as I said, conversion maybe requires, depending on your study and your outcome and whatever effect measures or types of data you have in your meta-analysis. So let's talk just briefly about continuous data and the effect measures related to them. So that we have the mean difference or difference in means. When all studies use the same scale, it's very easy to use the mean difference. So we compare the means between the groups who are, let's say, blood pressure intervention, a new intervention versus another commonly used drug, and we compare the blood pressure across the groups, we will do the mean difference. So we know when we combine the studies, we combine them and then we analyze them using the mean difference. The standardized mean difference, we use it when the same outcome is reported to different scales, as I said, like pain scale, sometimes depression, in which the scale or the unit are not consistent across the studies. And the standardized mean difference equation takes into account the difference in mean outcomes between the groups, and then divided by the standard deviation of outcome among participants. So the numbers will not be the same. So it's not, you might run analysis using mean difference and then you get different results using standardized mean difference, although the same are comparing means. So, but you should know which one is more accurate for your study, just to make it easier for you. Whenever you have the same unit, mean difference, the unit is different, the scale is different, you standardize mean difference. For the economist data, we usually have risk ratios. One of the very common measures in meta-analysis, risk ratio is it's more easier to interpret than other types of binary or dichotomous data measures. We can use odds ratios, risk difference, or we can also use the number needed to treat. So usually all of these can be calculated from the 2x2 table here. For instance, if I just know, for instance, the exposure status and then the disease or the outcome, here's the outcome status, and it's yes or no, and we have number of events, we can easily calculate this data. So even if the studies, individual studies, do not give me odds ratio, relative risk, or risk difference, or NT, I can calculate them from the 2x2 table, which is the number of events. If they report number of events, that will be sufficient for me to do the calculations I need to perform the meta-analysis. And usually for a randomized controlled trial, they will report number of events. The studies will not report risk ratios or odds ratios or risk difference. They will just report number of events. And you will take that information to calculate whatever you want as either risk ratio or odds ratio, and then combine them together and do the meta-analysis. For counts, we can't usually run meta-analysis straightforward for counts. We have possible solutions. We can dichotomize it. We can treat it as a continuous variable, or analyze it as rates using Poisson or models, different kind of models. In my experience, I see that we mostly do the first two, either dichotomized, like if I have a count, and then I can categorize it into two categories, either saying below a certain number, above a certain number, or I just can treat it as a continuous variable, although we acknowledge that it's not entirely continuous. For time to event data, the hazard ratios can be either from a 2x2 table, but the 2x2 table does not have time element in it. So you can either dichotomize it. So if a study, if an RCT is reporting time to event data, you can just use the number of events and then combine them, and then you calculate either odds ratio, relative risk, and then combine them with your other studies. Or you can take the hazard ratio and combine it with odds ratio and relative risk. As I said, it's not perfect. They're not identical. The hazard ratio is not the same as odds, relative risk, but you can still combine them and acknowledge that in your paper limitation. So which measure should I use? Should I go for mean difference? Should I go for a dichotomous one, the odds ratio, relative risk? Really what the necessary information trying to convey here, and what's suitable for your study design. Usually when I have RCTs, I can combine just the number of events, but when I have observational study, I might want to have combined adjusted odds ratio, relative risk, or hazard ratio. And what's statistically appropriate, of course, what makes sense for your type of measure, so which test to use, and what's also convenient for you to work with and you're familiar with. I would say these are the factors that will make me choose which type of analysis I will go through or effect measure I would use in a meta-analysis. Usually, as I said, we need to convert measures or results into a common metrics. So you can use, let's say sometimes we don't have the standard deviation. We only have mean, and we want the standard deviation to calculate the mean difference. You can convert p-values, f-statistics, or other statistics into standardized effect size metrics in a meta-analysis. You can convert median to means if you want to combine means. You don't want to combine medians because sometimes the results report means and other medians, and you want to combine them together. So you cannot just combine mean and median. You have to convert one to another. There are so many different ways of combining data. I always advise researchers to go through the Cochrane Handbook for meta-analyses. It has really some nice recommendations for data transformation, and they have some conversions. And they also have some ready Excel sheets in which you plug in your numbers and you get the converted data. But always just when you see your data, you see variability across the studies, I wouldn't be disencouraged. I would look and see what are the possible ways of converting my data into a common metric. So the second part is, so now I know my type of effect measure I'm using, and I want to combine my data in a meta-analysis. There are certain principles that we follow for combining data. For each analysis, one study should contribute only to one treatment effect. So this is really important for meta-analysis. Specifically, can only for each analysis, each study can be once added as a one time. So let's say you have a study that compares the effect of blood pressure in the population, and then you have it as in male and females. So you either, when you enter that study, you either enter the whole population or you enter the male and female separately. So you cannot have the same patients reported twice in different in one meta-analysis. You cannot have the same patients either in any studies. So let's say you cannot have the total population and then add the males and the females. You can't do that. You can either have the male and female, that will be considered as two different populations, or have the total population. So each study should give one treatment effect. And if the study reports subgroups, each subgroup should be separate. So let's say they have a study has total population outcome, and then it has it reported by obesity level, for instance, those who are obese versus non-obese. So you can take the obese and non-obese separately, consider them as two separate analyses, or the whole population. The effect measure may be for a single outcome or a composite outcome. That's also important sometimes. As specifically for the binary, this is very important for binary outcomes. When you have odds ratio, sometimes the odds ratio from observational study come from a composite outcome or a relative risk, come from a composite outcome. Composite, something like, usually I see very commonly cardiovascular diseases, other vascular studies in which the composite outcome would be death, time to hospitalization, or first hospitalization, or hospitalized, yes or no, and then will be also a new event with a new MI, new angina, or whatever composite outcome you have. So that will be the same. The composite outcome will be the same as just the binary outcome. So you will use the same effect estimate, whether it was a single outcome or a composite outcome. The outcome being combined should be the same or similar based on clinical plausibility across studies. So you should not combine outcomes that are very different from each other. I'll just give you an example that will help you also thinking about the composite and the different outcomes. So let's say you have studies that report you're interested in maybe statins' effect on cardiovascular disease mortality, for instance. And then you have studies that use, your outcome is cardiovascular disease mortality. So you have studies that report mortality and those that report cardiovascular disease mortality. And then you have to make the clinical judgment, whether you want to combine them together and say mortality overall, or you specifically want cardiovascular disease mortality. Or let's give another example. Let's say you're interested into cardiovascular events. And then in one of the studies, they report a composite outcome of cardiovascular events, including heart failure. Maybe you're not interested in heart failure. That's not doesn't make sense to add it with your other outcomes. So you might think of not adding that study or that outcome of that study because it has heart failure, and all of your other studies don't have heart failure in their outcome. So you have to think of what's clinically meaningful to add together. You can't just combine, let's say, pain scores for depression scales together. It just does not make sense. So yeah, whenever you and I know it sounds like easy. Oh, we're always going to combine the same outcome, but when it comes to reality and you open the studies and you start extracting the data, you're going to find that different outcomes, the same outcomes reported differently across studies. So you need to think of the plausibility and clinically they make sense to combine them or not. And know your question. The question drives your study selection, synthesis, and interpretation of the results. So that will, what are you asking? As I said, for example, cardiovascular death or mortality in general. So what's your question that also determine what type of outcomes you're going to combine together. So things you need to know before combining data, the biological and clinical plausibility of combining studies of different outcomes, the scale of the effect measure, I said, because you should know which type of effect measure you'll use based on the scale. And the fragility of small numbers. Studies with a small number of events do not give reliable estimates, and you always should remember that just they might disturb your results because of their small number of events or small number of data from the study. This to show you how small change can have a big impact. Here, for instance, this table, we have two studies, study A, and then we have study B. In study A, we have, for instance, 100 events in total, 1,000 patients population. In study B, we have one event in 1,000 people in the treatment arm. In the control arm, we have 200 events in 1,000, and in study B, we have 2 events per 1,000 subjects. If you calculate the rates, you're going to get, of course, here you're going to get the rate is 10%, here's 20% in the control and 20% in the treatment arm for study A. For study B, it's 0.1% and 0.2%. This is basically just the percentage of rates or events in the population. If you calculate the relative risk, it's going to be 0.5 for both studies. So if you calculate the absolute risk, it's going to be here 10%, and the study B is going to be 0.1%. So same change in one scale might have different meaning in another scale. So they're very different in terms of rates. When you look at the relative risk, it looks like the same effect, but it's not. So small numbers can really have a big, small change can have a big impact on your numbers here. So how would you analyze data for meta-analyses? First, you're going to calculate the effect size for each study. As I said, maybe you might need to convert some data. You might need to obtain some more information. Let's say they don't give you standard deviation and you want to calculate that. So you need to obtain that from the other variables they give you. You may need to convert continuous variables categorical or number of events, time to event into odds ratio or relative risk. So first of all, the first step I will be calculate the effect size for each study. And then you're going to combine them together, combine them through the different types of tests. As I said, depends on the effect measure you're using. So if you're using means, combining means is going to be mean difference. If it's means but different scale, standardized mean difference. If it's binary, usually we combine by relative risk. Then you're going to draw your forest plot. You can assess for heterogeneity, and then you're going to maybe do subgroup analyses or meta-regression when possible. I'm going to talk about some of these things in the few upcoming slides. So when calculating effect sizes, meta-analysis requires an effect size and estimate of the sampling variance for that effect size. So it requires two information. What's the, for instance, your effect size is mean, and what's the variance with that mean or the difference across the mean. Or if it's odds ratio, what's the variance with that odds ratio? It requires two information here. It requires the effect estimate, effect size itself, and the estimating the sampling variance of that effect size. So there's certain calculation that goes into that. Maybe you're not going to go to details. It's not under the scope of this lecture. But usually just let you know that papers do not always report effect size, or they report a different effect size than what you want in your meta-analyses. So you need to, as I said, calculate sometimes effect size. So they will, let's say you're interested in odds ratios, but they report number of events. But so you can calculate the odds ratio based on number of events or relative risk from number of events and so on. You would ask yourself when we calculating effect sizes. Am I meta-analyzing a descriptive statistics? Am I talking about means, standard deviation, proportion, comeback alpha, or am I measuring associations? Am I looking into correlations or regression analyses, or I'm doing differences, mean difference, for instance? So what am I trying to analyze? What am I trying to show at the end? Is the statistic reported directly? Do they do any conversion? Is the variance or standard error reported directly? Usually, in my experience, they are not reported, and you would need to calculate them from your effect measure. Do I have the sample size or total for the total groups, or in each groups I'm comparing, because you need the number of patients. Do not forget that you don't just need number of events or the outcome. The mean, let's instance, for example, blood pressure. You need also to know the number of patients in each group. And are measures of variability reported, standard deviation, for instance, for each study. So these are the things I would check mark or think about when I calculate my effect size. Once you combine effect measures or effect size and meta-analysis, there are different ways of combining them. Simple average method, weighted average, or calculating weights. There are different calculations that goes with each of these methods. And usually you can specify in statistical programming which method you use. I would advise just to be familiar with type of data. What are you trying to analyze to choose the best way of combining data and meta-analysis. And also, I would ask advice from statisticians if there's statisticians expert in analyses in which what is the best method for your data in terms of combining them, either using simple average, weighted average, or calculating weights. Now we're going to move on into random effects models or versus fixed effects models. So we talked about that type of data, the effect measures. What do they mean? What do we need to combine them together? And then once we combine them, what type of models we're going to use, random versus fixed effect models. So why do you have really two models? The alternative ways, there are two different ways of computing and testing the mean effect sizes across groups. Which one you use really depend on several things. How you conceptualize the source of variation among the studies or the effect size. Why don't all the studies have the same effect size? So if the studies are very similar together, I would go with a fixed effect model. If the studies vary in different ways, so I can go with random effect models. What do I mean by similar or vary? So similar in the design, they're very similar. The intervention is almost identical. The control group is the same. Let's say, for instance, you're comparing statin versus placebo. They're all comparing the same statin agent versus placebo in all groups, in all studies. The population is similar. The outcome is similar. The follow-up was the same. So when you have nearly identical studies, then you can combine the effect measures together using fixed effect model. But usually that's not the scenario, and studies vary differently. They vary in terms of could be the population of interest, could be in some studies more healthier, and other studies are more sicker population or older population versus younger population. The exposure itself or the intervention could be different. It could be different agents, different combination of agents, although I would always advise to use, especially for the exposure intervention, to be as much as possible similar. The control group, I find it to vary across studies. Sometimes the control group could be placebo, sometimes could be no intervention or usual care. There could be variabilities in the design in terms of the follow-up periods, for instance. So all of these usually vary across studies. So it would be more logical to use a random effect model in which it takes into consideration the variabilities across studies, and the fixed effect model does not do that. Also, general word of advice, sometimes when you have a low number of studies, even if they're different, but you have less than 5 studies, then you'd be able to use a fixed effect model, even if the studies are different. It's justifiable. There are some studies that support, methodological studies that support that. Because when you have a very small number of studies, once you use a random effect model, you're definitely going to get a very wide interval with your effect size, confidence interval, the effect size. So you're most likely going to get non-significant results, whatever you do, because the random effect model, the way it's calculated, it takes into consideration variabilities across studies. So that will create a larger or a wider confidence interval. So you're most likely going to get non-significant results for studies less than 5 using a random effect model. So it's justifiable for these studies, for a small number of studies, when there are 5 or less, to use fixed effect model, even if there's variability, but support that with evidence, I would suggest. So what are the fixed effect models? So fixed effect models assume each study in the meta-analysis uses the same or fixed operationalizations of the design condition, the same external validity elements, so population, setting, task, stimulus, all of these will be the same across studies, as I said. Based on this, the studies in the meta-analysis are assumed to be drawn from a population of studies that all have the same effect size, except for the possibility of sampling error. So the sampling error is inversely related to the size of the sample, which is why the effect size for each study is weighted by the inverse variance weight, which is usually computed from the sample size. See, these are the calculations involving the fixed effect model. So in concept, the fixed effect model assumes that the most important thing, it assumes that the population of the studies drawn from have the same effect size, except for the possibility of sampling error. So only the sampling error term is included in the fixed effect model. Models, on the other hand, they assume that different studies in the meta-analysis use different operationalizations of the design, the condition, or the exposure, or the follow-up, whatever, as an example, as I mentioned. Based on this, studies in the meta-analysis are assumed to be drawn from population studies that have different effect sizes for 2 reasons: either sampling variability, similar as the fixed effect, so assume sampling variability, but it adds on it another variability, the real effect size difference between the studies caused by differences in the design or whatever external validity elements. So the sampling error is inversely related to the sample and directly related to the variability across the population of studies. So I'm not going to go to the details of the calculation, but here the calculation that goes in the background when we calculate the random effect. And we should compute the inverse weight differently than the fixed effect model. So the fixed effect model takes into account only sampling variability. However, the random effect model takes into account the sampling variability and also differences across studies. So it takes into account 2 error terms and 1 error term. So you get a wider confidence interval when you do the random effects model. I think the most important thing for me here, the message that you need to realize is which model to use. There's the calculation per se. Most of the statistical programming, they already have this calculation inherited or coded in their system. But as a researcher is conducting, and especially as a clinician, maybe your interest is which model to use. And as I said, look really at the variability. If you think the studies are different, there are differences in the design, then I would go with the random effect model. And it's really just to note here that we choose the model we want to use in our proposal. We don't wait until we combine the data. We usually decide from the beginning. So whenever I'm planning to conduct an analysis, I'm usually familiar with the area and the studies that are in this field or in this intervention, using this intervention. And I will usually also be reading the literature, and will be reading some of the studies that were included in the meta-analysis. And once I believe there are differences going to be across the studies, then I should from the beginning plan to use a random effect model. So for instance, if you're combining observational studies, I would definitely always go with a random effect model. They're definitely not going to be the same. But if you're combining randomized controlled trials, you might end up with very similar studies, and you can use the fixed effect model. But you have to plan that from the beginning. So you have to, and if you change, you have to justify and just a refresher, I said we register our proposals in Prospero. So if you make any changes, a reviewer or anyone might ask why are you changing your analysis than the one you planned in your proposal. So you have to think from the beginning. And I don't like that analysis changes based on data. You should usually know what's the plan that you have from the start. So that you don't be biased. The data drives your analysis. No, analysis is driven based on the question you're trying to ask, the data, type of data you plan to obtain, and the information you collect from the literature review. So as just to sum this up, so when you have different studies, you're expecting differences across studies. From the beginning, I would plan to choose random effect model. And then I would use the fixed effect model and sensitivity analysis. So it will just, the results of that analysis can help you support your initial or your primary way of analyzing the data. If you think the studies are going to be very much similar, then from the beginning you can use fixed effect model and justify that by believing the studies are going to be similar across each other. Again, if you have a small number of studies, usually less than 5, you can go with fixed effect model, even if you know the studies are different because of the small number of studies, and you can run a sensitivity analysis using the random effect model. So generally, whenever I choose one model, I will have a sensitivity analysis using the other model, just to make sure my results are consistent or in the same, they're not widely different across different models. So really, when thinking which model to use, I will say the assumptions of the fixed effect model are less likely to be met than the random effect model. So the assumption that the studies are identical, even if there's a replication of trials, even if the trials are being replicated, there's still variability. There are maybe in different countries and different set of populations. They have different genetic material. They're being developed at different time points in a lifetime. So the guidelines of the treatment effect. So let's say, even if you're asking the same question, the same intervention, the same placebo control arm, everything is the same. It's an RCT, but one is conducted 2020 and conducted 2010. So the other treatments, the co-interventions that these populations will be receiving, or the diagnostic tests, are different across 10 years. So even if the study looks identical, but there are a lot of external validity issues that might affect and might not make them similar, identical as you might think. The sampling error estimate for the random effect model is likely to be larger, and so the results statistically less powerful than the fixed effect model. That's, as I said, because of the you include more sampling errors in your estimate here, so you end up with less likely to have statistical significance or less powerful results. It is possible to test to see if the amount of variability or heterogeneity among the set of the effect sizes is larger than would be expected. That comes from the same population. So rejecting the null is seen by some evidence that the random effect model should be used. So maybe even if you can do the heterogeneity testing, and then that will drive you or supports the use of random effect model when the heterogeneity is high. By this, we talked about the basic analysis, or how you would think of the effect measures you use, how you combine the data, and which model to use, random versus effects model. And now we're going to talk about reading the forest plot. So this is an example of a very basic forest plot, or a forest plot from from a study that was published a while ago. It was an antibiotic treatment versus appendectomy for uncomplicated acute appendicitis. And this forest plot is for the outcome was complications. So complications, yes or no, was a binary outcome. In this forest plot here, each line represents the study, as you can see here. The study here, each line represents a different study. And then each study has its own corresponding effect measure, which are, for instance, for this study, it's the first line, and then the second line for the second study, and so on. This effect measure, for instance, here was risk ratios. That was the effect measure used. So the outcome was complications, yes or no. So it was a binary outcome. One of the common measures we use here are risk ratios, meta-analyses. How is the risk ratio calculated? Calculated from the number of events. As we see here, this is the events and the total number of populations. So here are the events in group 1, This is the total population in group in study 1 in the antibiotic treatment arm. In the appendectomy arm, for instance, here at 24 divided over 119 subjects, total number of subjects, and so on for each study. So these are the raw data from the studies. These data here, I will say these are raw data from each study, and then you will calculate the in meta-analysis, you will calculate the risk ratio for each studies here. This is the risk ratio for each study, and then you're going to combine them in meta-analyses. So each study has an effect estimate and has a weight for each study. So these are the effect estimate in the figure scale, and these are the numbers. So the line here, the solid green line, is the line of no difference, in which if a study crosses that line, there is no difference, in which the relative risk crosses an interval, and that study, whose interval crosses 1, there's no difference. For instance, let's look at the first study, 2011. There were 14 cases of complications in 120 subjects who received antibiotic treatment, whereas there were 24 cases of complications in 119 subjects who received an appendectomy. The risk ratio for this study was calculated to be 0.58. This is from the 2x2 table, just from knowing the number of events. You can get it as 0.58. The confidence interval is 0.31 to 1.06. So it includes the value 1 in the middle and somewhere in this interval. So it means, and if you can see here, it slightly crosses the line of no difference. Here, the line of no difference slightly crosses the line of no difference. So this is the effect size and effect estimate for each study. The weight of each study, here's the percentage. For instance, the study weight was 21.1%. Weight, it really reflects the amount of information that study gave me. It's usually reflected by the number of sample size. But for binary outcome, you look at the number of events. So the study that has the most event rate will have the most weight. So here, study by Hansen 2009 is the study that had the most event rate compared to all other studies together. So Hansen will be the largest, or it will take the highest weight. So don't just look in the number total, 200 and 100, no, you look at the number of events. So whenever you have a large number of events, the study that has the largest number of events will have the highest, or the largest weight here, which weighs 55.7. So the study results are really driven 50% of it by this study. If you notice, the effect sizes for all of the studies, they cross the line of 1. As we see here at the interval, all of them, they go from below 1 to above 1 in all of the 4 studies. The diamond now represents the overall effect size in which we combine all the studies together. So this is the overall effect size. This is a diamond, which usually represented as a diamond, but it could also be in a square or circle depending on the study figure. So the diamond here represents the overall effect size. The effect size overall for the studies was 0.69. And if you see the interval here, it goes from 0.54 to 0.89. So it does not really cross 1. So the overall effect here is significant. It does not cross 1. It means that people who receive antibiotic treatment had lower rate of complications than people who received appendectomy. So in this meta-analysis, we have a favorable effect of antibiotic treatment versus appendectomy. The size here, I'm just trying to show you that the size of the line is how wide is the interval, the size of the confidence interval in each study. The size of the diamond, how big or narrow it is, really reflects the confidence interval for the overall effect estimate. These are just as I said, the raw data from each study. This is the risk ratio. As I see here, this is the word fixed. It just tells you that they use the fixed effect model in their meta-analysis. And this is the weight and the risk ratio as we discussed. The information here, this is the test for overall effect. The overall effect was significant. The z-score was 2.91, reflecting a p-value of 0.004. And we can see that from the interval here, as I said, there's a significant effect and favoring the antibiotic treatment arm. This line here talks about heterogeneity between the differences across studies, and the test of heterogeneity. This is done with a chi-square test for heterogeneity. We have a degree of freedom of 3 because we have 4 studies, so it's n minus 1, so it's 3. The p-value was 0.78, it means was not significant. I-square is 0%. And we're going to talk about heterogeneity in a few slides. Just in summary, it means there's no differences across studies. This supports the use of a fixed effect model. So this was basically how you would read a forest plot. Now we're going to move on heterogeneity. What does the I-square mean, and when do we do, and how do we subgroup analysis when possible? Heterogeneity means the differences across studies. Possibly we have 3 types of heterogeneity across studies or in analysis. There could be methodological, or clinical, or statistical. Methodological and clinical are things that we cannot calculate, but the other things that we think are differences across studies, either in terms of the methodology, like study designs are different, or there are some differences in the design or settings that can affect the methodological similarities across studies. Clinical is when we think about the participants' variability in participants, variability in interventions or co-interventions. This affects clinical heterogeneity, but the statistical heterogeneity is the test that we conduct to see if there's differences across the studies, or they're just due to chance, the difference due to chance or not. And the test for heterogeneity comes as an I-square usually, and it ranges from 0 to 100%, in which there's 0% means there's no heterogeneity, but 100% means there's a lot of heterogeneity. And therefore, in terms of the test comes with a p-value. For heterogeneity, the p-value here we look at is 0.1. If it's less than 0.1, we consider it significant heterogeneity across the study's differences. Usually, statistical heterogeneity is driven from either clinical or methodological, or both of them, or means there are differences across the methodology or the clinical interventions or population across studies. So whenever there is a statistical heterogeneity, always look at the studies. What's causing this heterogeneity? What's different across the patients or the population or the methodology that could drive this statistical heterogeneity? So first of all, when you look at the heterogeneity of differences across studies, I would say the first thing you would do is just visual inspection of the forest plot. It can guide you before even reading the I-square. So let's look at the results from 2 meta-analyses, here from meta-analysis A and from meta-analysis B. So in meta-analysis A, we have 4 studies. We have also 4 studies meta-analysis B. And we can see in meta-analysis A, there were 2 studies favoring treatment and 2 studies were maybe not significant or more towards favoring control. The overall effect was I'd say relative risk using a fixed effect model was 0.69, and the interval went from 0.51 to 0.93, in which it favors the treatment. And the p-value here was significant. So there's significant differences across the intervention treatment arm, in which treatment arm looks better in this example. Here, heterogeneity was really high. The p-value was less than 0.001, and the I-square 95%. Even before looking at the I-square, you can see that the studies here are really different. These studies are not the same like these studies. But we look at meta-analysis B. We have 4 studies, and they all showed really no difference between, each study individually showed no difference between treatment and control arm, if you can see at these results here from the 4 studies. But when you look at the overall effect, you really get a similar results as you saw here. We got a 0.71 relative risk, and the interval was significant. It ranged from 0.53 to 0.96, favoring a treatment arm, and the p-value was 0.02. So we really got similar results. And in both of them, we use fixed effect model just to show you the numbers. Of course, in this study, I would not use a fixed effect model in a study A. Here, the I-square was 0%. The p-value of the I-square is 0.97. So there was no differences. So just visually, you can tell there are differences just by looking at the line of each study in the forest plot, even before reading the I-square. With the heterogeneity p-value mean? The null hypothesis here that the test of heterogeneity is the underlying effect in each study is the same. That's the null hypothesis. We usually, whenever we do a statistical test in our studies, we want the p-value to be significant. Except here for heterogeneity, you want it to be non-significant because you really want the null hypothesis. You want to say that the effect is the same in each of the studies. So the threshold here is 0.1. It's not 0.05. Okay, so we're more strict. We don't want any variability across studies. If there is a low p-value, if less than 0.1 means there's random error is unlikely. It's unlikely to be random error. There's an actual error or the actual differences across studies. It means that heterogeneity exists. That means that a single summary estimate is not appropriate. Usually means maybe combining the studies is not really the best way to do it. There are differences across studies. When the p-value is high, means heterogeneity is not a problem most likely, and you're more confident with the overall summary. The I2 statistics is a percentage, estimates the percentage of variability of the results across studies, and tells you if it's likely due to true differences or not, or due to chance. In terms of interpretation, we look at the percentage. Usually if it's 0, it's excellent, means there's no difference, and a single treatment or pooled effect makes sense. It means that you don't need to do subgroup analysis. One effect is the same because the studies are similar. Usually if it's less than 0.25, it's small heterogeneity that we don't need to do anything about. And if it's 0.25 to 0.5, it's moderate. And if it's more than 0.5, it's large heterogeneity. Really, the cutoff points I'm showing here are there's no standardized cutoff points. You should, before you do your study, when you write the proposal, you choose which cutoff points you will consider for moderate or for high heterogeneity or large. Some studies use 0.75 to consider it large heterogeneity, while others use 0.5. So there is no really practicality in which one is better. Of course, if you're being more strict, you will use a 0.5, but there's nothing that specifies that there's a certain percentage that you should go with. But these are the usual cutoff points here. Whenever you have heterogeneity, you should look for explanation. Why there are differences across studies. As I said, usually there's a methodological or clinical differences, and maybe you should not be combining the studies in one meta-analysis when you have high heterogeneity. There is high heterogeneity, and if you study when there is large or high heterogeneity, look into the author explanation of the meta-analysis. Why did they find high heterogeneity? And think about the prior hypothesis rather than post-doc data dredging. So I would rather, from the beginning, plan if you think they're going to see heterogeneity, or you think there are going to be differences across different populations. So a priori, think of the possible subgroups you want to analyze your data on, so it can explain possibly any heterogeneity you find in your meta-analyses. But always exercise caution when doing any recommendations based on treatments and where the summary estimates have a large unexplained heterogeneity. So when the I-square is very high, I would really be cautious about the recommendations or the results of the meta-analysis. And unexplained means that there is nothing to explain it. That if you do subgroup analysis, if you do any meta-regression, the heterogeneity will not decrease, will not be different. So you cannot really explain why there are differences. So in that scenario, I would be very cautious when recommending results from meta-analyses with high heterogeneity in their outcome. Are your results, and maybe it's a way of thinking of subgroup analysis. This is an example of a paper I got from the Cochrane database, systematic reviews. The question was, should we administer IV magnesium to patients presenting with acute severe asthma? So they had they pulled the effect using subgroups. So they had the primary outcome here was admission to the hospital. So that was the outcome. They had the severe group and they had the mild to moderate group. And also they had the overall, in which they combined both severe and mild to moderate. I'm going to first start with the overall effect estimate, in which they combined the patients who were in severe group and those in the studies in the severe group and studies in the mild to moderate group. The overall effect estimate here, as you can see, it's not a diamond. As I told you, it not necessarily would be a diamond. Here it's a circle. Was 0.7. it's a relative risk, and the interval was 0.51 to 0.98, and we can see it did not cross the line of no difference. So there's a significant improvement with magnesium sulfate compared to placebo. But the I-square for the overall effect was a bit high. It was 56%. The p-value was 0.4, meaning there is probably a difference here across studies that not just due to chance. There's a true difference between the studies. So what did the authors do here? They divided the analyses by subgroup. They did severe group and mild to moderate group. And then when they combined the studies that assessed severe patients, the pooled effect estimate here was favoring magnesium sulfate. The relative risk was 0.59, and it was significant, as you see from the interval. And you can see that it does not cross the one. And you can see that even the effect size now is more precise. Look at the I-square, it went down to 40%. And when they did the studies separated for the mild to moderate group, the overall effect size here was not different. There was no difference between magnesium sulfate and placebo. The relative risk was 1.96, and the interval crossed 1. The I-square here was amazing. It was went down to 0%. So here, subgroup analysis helped explain heterogeneity across the studies. So now you will be, if I see such results, I would recommend magnesium sulfate in the severe group, but I would not recommend it in the mild to moderate group. If you did not perform subgroup analysis, you will not be able to come up with this recommendation. Analysis is one way to try to explain heterogeneity, and we sometimes conducted not just to explain heterogeneity, maybe from the beginning, I also want to see the effect across subgroups. I want to separate my analysis across different subgroups of patients. It's conducted to examine important differences in the treatment effect and how they vary across certain subgroups that you can think of. There are different types of subgroups. I'm just giving you some examples. For instance, type of patients, you can sicker versus less sick, as we saw in the previous example, severe versus mild to moderate. It could be across treatments in which treatment with different drugs in the same class, for instance, the statin example we talked about a few slides ago. So you can have different types of statins. You want to see if the treatment effect will maintain the same across different treatments. Just to note here, we're not saying if a treatment is better than if drugs in the same class are better than each other. The regular meta-analysis does not do that. To do that, you need a network, and that's not in our discussion today. But in the subgroup, you can see if the effect is still the same. Let's say you're saying you're checking the effect of statin on mortality, cardiovascular mortality. So you want to see this, and you saw that when you have overall statin compared to placebo, it improves, it decreases cardiovascular mortality significantly versus placebo. And then you compare that across different statins. So for the first, you see for statin A, it still improves mortality compared to placebo, and you see that for statin B, does it still improve mortality versus placebo? But it does not tell you if statin A is better than statin B. That is not what it does in meta-analyses. The regular meta-analyses is not capable of doing that. To do that, you will require more different techniques and advanced techniques such as network meta-analysis, which is not our scope, as I said here today. And you can look at the also time when the study was conducted. Was it in the early 90s or 2020s, and so on? So there are different subgroups. And the reason that would drive me to do a subgroup is whenever I'm designing a meta-analysis, am I thinking there will be differences across studies? And these differences are going to be explained by subgroup analyses. So they should be a priority. I should think of that before I write and when I at the proposal stage. It doesn't mean that you cannot have a post hoc subgroup. Sometimes, let's say, I don't think about the certain subgroup. Let's say I do not think that gender will be different, and then I see differences across gender. I see studies who are compared male and female, they get different results. So then, okay, I did not think about that initially, but I want to add that. But that's not the preferable way. But I'm just saying it's not impossible. That sometimes we end up doing this because sometimes we don't think that certain subgroup variables will cause differences across the effect estimate. And we only notice that after we run our meta-analysis. Subgroup analyses really suffer from some major limitations. Really, most trials are underpowered to detect the overall effect sometimes. You don't have enough studies. So they have negligible power to detect subgroup differences, even if they are large differences across subgroups. But if you don't have a large sample size in terms of large number of studies, you will not be able to find differences across studies. The Cochrane really recommends that you have at least 10 studies to perform subgroup analysis. So maybe you find high heterogeneity. Maybe you can think of a lot of subgroup analyses, but if you have less than 10 studies, you're not going to be capable of doing the subgroup analysis, but just because the sample size of the studies, number of studies is just very small. So finally, just a summary to wrap up today. I just talked briefly in the beginning on how to conduct semantic review and meta-analysis and the just basic steps that involves doing one. And then we took some time discussing the effect sizes. What do we mean by an effect size? How do we compute an effect size? And then how are we going to combine them together? And should we use random versus effect model? Really depends on the differences across studies. If you think there are differences, then always go with a random effect model. And if you have a small number of studies, less than 5, then it might be just advisable to use the fixed effect model. Then finally, we talked about heterogeneity and the differences across studies and when to use subgroup analysis and what do they mean. Thank you so much for listening to this lecture or loading dose. I hope you enjoyed it, and I hope it gave you some information that you need when you conduct your systematic review and meta-analysis. And I wish you best of luck whenever you're conducting one. And thank you so much again.